Today's webinar is entitled A Strawman Process for Solving Ill-Structured, Wicked, Messy, Chronic Problems, a Healthcare Example. During the presentation, you may type your questions into the question box and they will be answered at the end of the presentation. Without further delay, it is my great pleasure to introduce world-renowned experts in the theory of constraints, our presenter today, Jim Cox, and panelist, Ellie Schragenheim. Gentlemen, the audience is now yours.
Hi, everyone. I'm Ellie Schragenheim. Thank you, Jennifer, very much. And we are really looking for you to be our really great CEO for TOC ICO. And all the listeners, I think we have a very special presentation today by one of the biggest exponent of TOC I'm so fortunate to know. Jim Cox, I'm always fascinated by the stories that he heard Eli Goldratt back, I believe, in '83 or something like this, speaking about cost accounting, enemy number one of productivity. And he was so shocked that he went to Eli to say that he did not like this idea at all, and then was dragged by Eli and Goldratt to a pretty long, nicely discussions, and eventually Jim Cox really became one of the biggest names in TOC. And what we have today is this kind of rare combination between pure academics and someone who really does things on the floor, go in, really look on the healthcare, medical care, and come up with amazing new thoughts. And I really ask you to listen very carefully to this kind of between practitioner and the academics all in one. So Jim Cox, I give the stage to you to lead us into how to solve ill-structured problems.
Good morning. I'm Jim Cox. Thank you very much for that warm welcome. I'm here to talk today and present what I consider a straw man process for solving ill-structured, wicked, or messy problems. It's not the final solution. It's what I've come up with after 9 years of wandering in the healthcare area. As part of my presentation, I use a lot of abbreviations, some from the healthcare area, some from ill-structured problems area, and some from TOC. So if you're looking at this presentation at another time, these are some of the abbreviations that I use, and it's probably good to print this out if you're on your own and looking at the PDF of this presentation. I'll try and say the terms as I go through there instead of the abbreviations, because we have people that have never heard anything about TOC, and this is their first or their introduction to TOC. People that are not familiar with healthcare terminology, so on and so forth. I'll talk about an analogy, my productivity journey in healthcare, and it's a journey of exploration, a very unique type situation. And I think if you reflect back on your own journey in a given topic of TOC, you'll find many of the same things. I start with a quote by T.S. Eliot: "We shall not cease from exploration, and the end of our exploring will be to arrive where we started and to know the place for the first time." As you see in my journey, I keep coming back to the initial stage of my journey, that starting point, with more knowledge that I have learned, and it changes the way I view that point. Hopefully our journey through this presentation not only provides insights into how to approach ill-structured problems, but also into how to identify and address our global healthcare problem. Let me have some acknowledgements here, because I didn't get to where I'm at by myself. And I go back to a quote that Ellie used many times. It's from Isaac Newton, and it is, "If I have seen further, it is by standing on the shoulders of others." These are some that provided the foundation for where I'm at. Certainly Ellie Goldratt and his discussion of having a full life. If I had a question to ask him, though, it would be about setting a life goal. He talks about setting a life goal, but my journey, as you see, just sort of meandered along the way, and other people provided opportunities that changed that life goal. I'd like to thank my daughter and son-in-law, Tim and Laurie Robinson, who started me on the journey in healthcare. Also, Alex Knight, Vicki Mabin, Boaz Ronan, Roy Stratton, and Baha and Ozu, and they shared willingly their knowledge of TOC in healthcare. In fact, Boaz and Baha have books written on the application of TOC in healthcare. And then I need to thank Russ Johnson and Ellie Schragenheim for their prodding and making me change my goal as I went along this journey. Along this journey, I met two people, Gustavo Bacular and Michael Curtis, and this is the new breed of TOC healthcare experts. The sky is not the limit for either one of these gentlemen. I think they'll do some great things in healthcare using TOC. And then in preparation for this program, Ellie Schragenheim asked me to discuss some other areas where the solution might apply. So I looked at TOC for education and the prison problem, the recidivism, which is convicts ending back up in prison, which is a massive problem in the US and maybe worldwide. I went back and read Christina Chan's chapter in the TOC handbook on teaching TOC in prisons. I think that is excellent reading for anybody that wants to really understand buy-in. The last person is John Wood, a person I've never met. I used a puzzle in this and wrote the publisher, and John immediately wrote me back with permission to use the puzzle that I use in here. My productivity journey, it starts with the starting point, point A, and it tries to end at point B, the goal of my journey. As I said earlier, that goal keeps moving. Ends late August of 2010, my son-in-law and daughter and our families went on a family vacation at the beach, and my daughter asked me, Tim, her husband, had just walked into a medical practice as a partner, only to find out that the practice wasn't doing well financially. So my daughter asked me, also a doctor, asked me if TOC might be able to help in the healthcare field, and would I be willing to look at their operation. I didn't know much about healthcare at that time except as a patient, but we started on that journey September 2010. On that journey and looking at that one medical practice and analyzing the UDI's undesirable effects, the problems that people saw in that practice, I came to the conclusion that there were two core problems. One was poor schedule design, and the other was the inability to execute the schedule. We implemented TOC starting in September. The solution was highly successful, and we reaped the awards by January. The major implementation had been completed. There was still some arm wrestling with some of the partners after that, but they had immediate and significant improvement in profit. I think it was a 20 or 37% improvement in revenue, 57% increase in net ordinary income. They went from over 20% no-show rate to around 3% no-show, late cancellation, and no appointment schedule rate. In 2015, that percentage was at about 2%. So they had immediate improvement. Along that path, I started looking at, in January 2011, I started looking at the academic literature and practitioner literature, figuring that there were probably things that we could do that we didn't do that would improve their practice even more. So I continued examining that literature, but in 2012, Tim and I presented the case study of the implementation at the TOC ICO conference. I wanted to do that to have the top TOC experts in the world to review the work and tell me if I had done anything wrong. Along that path of looking at the academic literature, I found no better solution in either the practitioner or academic literature, but I did find that the problems that the practice faced seemed to be universal. It didn't matter what country you were looking at research from, what type of practice, what type of medical specialty, whether it was for-profit, not-for-profit, a state-run medical system, or individuals owning the practices. The UDIs, the problems were generic. So along that path, I started thinking, well, if the problems are generic, maybe there's a generic solution to outpatient scheduling. So that's changed the focus. And notice as I show you this slide, the figures keep expanding. And that's what happened in reality. The system that I was looking at kept expanding and getting bigger with additional necessary conditions and facts appearing. In 2015, I came across the term ill-structured, ill-defined, wicked, messy in the academic literature, and they all seem to focus on having the same definitions. So they were synonyms for each other, and they were written about by many in the academic literature. I came across the term satisficing. As I moved in time on my journey in 2018, Russ Johnson, who I acknowledged earlier, asked me to speak to his graduate class at Washington State on my research. And I spent about 3 or 4 months preparing for that presentation. And I ran across the terms inherent classification and inherent simplicity, terms that Goldratt developed, and then multi-framing, and a key term, hierarchal decomposition principle. That presentation went well, and then somehow Ellie Schragenheim found out about it. And Ellie asked me to speak at the TOC ICO conference, but he did want me to talk about healthcare. He wanted me to expand the problem and talk about how I solved a wicked problem the health care problem. So I spent about 4 or 5 months trying to figure out what was the process I followed in doing this, and to document the process of solving a wicked problem. So that gives you my starting point and where I'm at now, and presenting how to take an ill-structured problem, ISP, and break it down into components that can be solved by TOC experts, and that's well-structured problems, WSPs. So I'll present that process as a strawman process, hoping that you'll take it and you'll try it out and you'll improve it, and then make presentations on those improvements. Back in 2010 in the implementation, these are the 2 clouds that were developed from the application of TOC in that one practice. And I bring this forward because the B and the C in the past design are significant in the solution for solving this healthcare ill-defined problem. Those requirements are that the practice or the organization provide timely, excellent patient health care, and the requirement that the provider has to have high utilization. And you can see that both of these are required to achieve having an ever-flourishing medical practice. So those 2 requirements I'll come back to later on as being requirements, the core requirements for developing an effective solution to the healthcare ill-defined problem. Items that I need to distinguish between as we go along. Most people in life talk about problems. I'm sick. I'm trying to get a doctor's appointment. The problem of getting an appointment 2 weeks from now when I call today and I'm sick is a problem. The core problem, though, that causes that is the doctor's inability or the provider's inability to schedule effectively. So what TOC tries to do is go from the symptom, what regular people think are the problems, and dive deeper by asking why and using logic to come down to the core problem in a given environment. The term classification and inherent classification. People talk about classification all the time. In TOC, we talk about inherent classification. I'll define that shortly. People also simplify problems, researchers, academic researchers in particular, so that it can be solved with mathematics. So they simplify problems in any environment. In TOC, we look at the inherent simplicity, the causality of that environment. And we want to understand the causal relationship, and that provides the simplicity in complex environments. A link versus a chain or a network. People talk about an organization without really understanding the full system and how it operates within a given environment. The provider schedule versus what I call the provider appointment system or scheduling system, and I call that PASS. Schedule design is written up significantly in the practitioner and academic literature and in discussions. But if you have a TOC perspective, you realize that you have to execute that schedule. So part of that PASS, that scheduling system, is the execution, effective execution of the schedule. And then in the TOC environment, we when we're moving from a normal environment, traditional environment, to a TOC environment, we encounter chaos. And in TOC, we define chaos as being complexity, uncertainty, and the use of local optima. We have processes of ongoing improvements, tools to address each one of those sources of disruption. The outline of my presentation is this. I'll give you some problem examples of wicked problems, and I'll define wicked problems. I'll provide 8 principles, concepts, and tools with examples used to convert an ill-structured problem to similar or dissimilar, well-structured problems. I'll use my puzzle analogy and wicked problem solution process. I'll talk about the solution process, apply it to healthcare, provide a direction for a solution that I probably won't have time to cover, both in education and in recidivism. That structure is 2 stages. The first stage is of significance because it gets you from ill-structured problems to wicked problems, 7-step process. And the second stage is, now that we have a well-structured problem, solve it. TOC experts know how to solve well-structured problems very effectively. They're doing it all the time. I've just got to show them how to go from the ill-structured problem to well-structured problems. So that provides you a direction of where I'm going in this presentation, what my goal is. An ill-structured problem, it goes by many names: ill-defined, ill-structured, wicked, messy. If we look at the definitions provided in the literature, we find that these terms are really synonyms provided by different researchers to describe messy problems. They include healthcare. Many researchers talk about healthcare as being one of these problems. They talk about government being one of these ill-defined, wicked, messy problems. They talk about education. In these areas, we spend massive amounts of money and our return is not what's expected. So no matter how we approach the problem, it seems to, we don't have significant rapid improvement, which is what we have with TOC implementations. Recidivism is the other I pointed out, and there are a number of others that are on the horizon in the US and in many other countries. Immigration, the opioid crisis, poverty, the justice system, the US pharmaceutical supply chain with all the rules and regulations placed on that supply chain of pharmaceuticals. Definitions related to ill-structured problems. In '62, Simon provided this definition of a complex system: a system made up of a large number of parts that interact in a non-simple way. As you see on most of my slides, I provide a reference, and at the bottom of the slide, the citation. So if you want to learn more about that specific topic, that's a pointer of where you might start. A chaotic environment, and this is just out of a dictionary, a system in a state of complete confusion or disorder. Ill-defined problem. This is by Rittman. A problem that doesn't have clear goals, operations, or an expected solution. Ill-structured problem by Simon, his definition. A problem whose structure lacks definition in some respect. Ackoff describes messy problems. Managers are not confronted with problems that are independent of each other, but with dynamic situations that consist of complex systems of changing problems that interact with each other. Situations in which there are large differences of opinion about the problem or even on the question of whether there is a problem. He goes on to say in a later article, a mess is a system of problems. A system is a whole that cannot be decomposed into independent parts. From this, it can and has been shown that a system always has properties that none of its parts have, and that these are its essential properties. I highlighted in bold a part that I want to come back and address, and that is a whole that cannot be decomposed into independent parts. In my solution process, we in fact solve the problems as independent parts, but we link the parts together as a larger system, the messy system, to provide the solution. So I hope you can follow this. I'm pulling from several other areas other than just gold rat, and I try and acknowledge those if you want to learn more about that specific area after the presentation. That's the reference for the takeoff material. And what I want you to understand is, even within TOC, this is a famous quote: the sum of the local optima is not equal to the global optima. And that is true. And what Aristotle said, and I believe to be the fact in solving ill-structured problems, the whole is greater than the sum of the parts. So I believe that in our solution process of ill-structured problems, when we look at the much larger system, we get many, many more benefits much quicker than not. Characteristics of an ill-structured problem applied to healthcare. This is Churchman's work. He had 4 characteristics of a wicked problem: incomplete or contradictory knowledge, the number of stakeholders, opinions involved, the large economic burden, and the interconnected nature of the problem with other problems. If we look at healthcare, we find that the incomplete and contradictory knowledge, we look at varying healthcare statistics on the internet. If you go out there and look at the no-show rate, you'll have a number of different papers, even the CDC, Center for Disease Control, with statistics of healthcare, and even within the CDC, the reports conflict. So across the internet, there are wide variations to any question you ask. And if you read articles in healthcare, everyone is blaming somebody else for the problem. The number of stakeholders and opinions are involved. Here I've listed some of the macro stakeholders in healthcare: the Affordable Care Act, the insurance companies, Medicare, Medicaid, so on and so forth. And at the micro level, the owners of the medical practice, the providers, the patients, the clinical staff, schedulers, so on and so forth. So if you ask any of these providers or any of these stakeholders, you would get a different perspective of the healthcare problem at the macro and the micro level. Large economic burden. The U.S. is a prime example of that. Healthcare is now $3.5 trillion annually. That's 17, and I think it just hit 18% of the gross domestic product. But we still have over 12% of the population uninsured. And that, if you just looked at that percentage there, you would get a wide variation of the percentage uninsured, for example, on the internet. The interconnected nature of the problems: you cannot talk about healthcare without talking about poverty. You cannot talk about poverty without talking about the level of education of people in poverty. If we looked at the types of hospitals and the interconnected nature. We have VA hospitals, private, public, so on and so forth. And as I'll show in here with a brief example, many times the proposed solution is often worse than the symptoms that we encountered and tried to address with that solution. So the field of healthcare has been examined since 1952 in the academic literature, and wicked problems have been discussed for almost that same length of time. I like this quote by Churchman. In a management science editorial, Churchman discusses a seminar Riddle gave on wicked problems and stated, one is led to conclude from the discussion that the membership in the class of non-wicked problems is restricted to the area of play, nursery school, academia, and the like. So what Riddle was saying is that almost every problem we look at is really a wicked problem, not a problem that's quite simple, but we try and simplify those problems, those wicked problems, so we can solve them. And this is what the remainder of his quote is about. Sometimes, as in OR, it consists, and he's talking about the approach, consists of carving off a piece of the problem and finding a rational and feasible solution to this piece. In the latter case, it is up to someone else, presumably a manager, to handle the untamed part. A better way of describing the OR solution, operations research solution, might be to say that it tames the growl of the wicked problem. The wicked problem no longer shows its teeth before it bites. An interesting observation, I believe. Goldratt, in talking about this complexity, his view is the more complex the situation seems to be, the simpler the solution must be. He goes on, the admiration with sophistication is totally wrong. The key for thinking like a scientist is the acceptance that any real life situation, no matter how complex it initially looks, is actually, once understood, embarrassingly simple. Moreover, if the situation is based on human interactions, you probably have enough knowledge to begin with. Totally different end of the spectrum. In this presentation of solving wicked problems, I'll talk about these concepts. The principle of bounded rationality, of being a satisficer in decision making. I'll talk about inherent classification, inherent simplicity. TOC experts know those terms there very well. I'll provide a brief explanation for those in healthcare or new to TOC so they can follow what I'm saying. The principle of hierarchal decomposition. I ran across this article by Simon in 1962, and it is a key to solving wicked problems. The fifth point is the principle of time-based dependency. This term or this tool was developed by Alex Knight in 2015 and illustrated in his TOC ICO presentation at an annual conference. It's funny because I ran across this and he never named it, so I contacted Alex a couple months back and said, hey, this concept, give me a name for it. I'm going to use it in my presentations, and I think it's significant. So he came up with time-based dependency. So being an academic, I added principle to it so we could use it in the academic literature. But that also is significant to solving this problem. And then I use the concept of multi-framing and the evaporating cloud. This was first discussed by Vicki Mabin and John Davies in 2004. Many of you know these two TOC experts. And then I invented, sorry, to give myself praise, this is not a great invention here, but I invented this concept of a strategic leverage point. The TOC dictionary defines a leverage point, but that's talking about an organization or something like that. I'm moving up to a higher level system, so I needed a different term to identify how you manage that higher level system. And then I use many of the tools of TOC, processes of ongoing improvement, particularly the three processes there, and then the thinking process. So those are the basis for the whole solution process. Let me get into detail. Simon, in discussing decision makers, said they were satisficers instead of optimizers. In other words, and I believe you'll agree with this totally, given bounded rationality, which means the decision maker has imperfect information, lives in a world of uncertainty, complexity, and time constraints, it must make a decision now. The decision maker selects what he or she perceives as a good enough solution at that moment in time. So most decision makers are satisficers in everything they do and not optimizers. Inherent classification in science. In 1988, in the Theory of Constraints journal, Goldratt wrote about the three stages of science: classification, correlation, and cause and effect. And that a science becomes a true science when it's at the cause and effect stage of science. He discussed classifications in science. The classification of heavenly bodies as stars, planets, meteors, and comets. People in that area of science defined each of these terms: a star, a planet, meteor, so on and so forth. And they did that for the purpose of identifying similar celestial bodies. So the classification scheme's purpose was to classify heavenly bodies so that we could identify similar heavenly bodies. Goldratt talks about the periodic table in chemistry. Mendeleev's contribution talks about the rows and what's in each row, the columns, what's in each column, and the purpose of that table was to predict missing elements, reactions between elements, and properties of elements. So there was a purpose to the classification scheme. An inherent classification is that classification that allows you to achieve the purpose you want to achieve. Back in 1988, Goldratt did not use the term inherent classification. He used that later, but his examples link the classification scheme to a purpose. And then the last he discussed was Darwin's contribution and the tree of life, and the purpose of that was for people to understand the evolution of species. Goldratt defined inherent classification in 2010, and this was from a correspondence. Goldratt wrote an email to, I assume, various TOC experts, or what he thought were experts, since I was in that group, about what he wanted to talk about in 2010 at the conference. And in the email, he wrote this. He said, the most intuitive structure to a body of knowledge is classification. But as I already explained in the last edition of The Goal, and that's the reference there, and it's my edition, classification is really meaningful only if it is the inherent classification, a classification that stems from the basic element of cause-effect. No problem. The mere fact that there is a guiding principle indicates that the inherent classification is at our grasp, probably already exists as one of the subjects. Therefore, a good frame will exist if the guiding principle is used to logically develop the sequence in which the classification emerges, and to explain the subject at its proper place, the place provided by the classification. So this email was the first time he used, I think, the term inherent classification. But he mentioned the definition in chapter 38 and gave several examples. So if you go back there and read that and then come back to this email correspondence, it'll make much more sense, I think. Let's talk about some examples of inherent classification: production operations management. How does one inherently classify resources to maximize production? If you're a TOC expert, how do I classify those resources? The inherent classification to maximize production is identify the constraint or constraints and the non-constraint. That allows me to determine the inherent classification or the inherent simplicity based upon that classification, so I can achieve the purpose of maximizing production. How does one inherently classify resources to schedule production? We know that the constraint is work center 3. The others, WC10 is another work center, so on and so forth. We, in fact, use the inherent classification to schedule production as drum buffer rope and simplified drum buffer rope. So that classification scheme applied to scheduling allows us and provides us tools to plan and control how organizations schedule and execute production. How does one inherently classify manufacturing plants? We're going to a bigger system than just the drum buffer rope. We're up at a much higher level of manufacturing plants. How do we do that to plan and control? The inherent classification of manufacturing plants to plan and control is the IVAT analysis. We have some plants that the flow looks like an I. We have other plants where we have divergent points where the flow and making the products looks like a V. We have others where we take a lot of parts and we put them together to make a product, looks like an A, and the flow of parts. And then we have a T plant where we have several features and options to the products, and there's a different way to manage the control points in each of those. So let's move over to managerial accounting. How does one inherently classify the chart of accounts to make effective decisions? We can go through highly sophisticated accounting processes to make decisions, or Goldratt classified these charts of account into throughput, inventory, and operating expense. So he looked at the inherent simplicity. He did not simplify. He looked at the inherent simplicity to achieve the purpose of making decisions, financial decisions, and that was to use throughput, inventory, and operating expense, which are very simple to compute to make decisions. If we looked at the inherent classification of identifying a problem and a solution, how does one logically identify, analyze, and solve a chronic problem? The purpose of the inherent classification of questions is to change question sequence. Instead of trying to answer hundreds of questions that are posed to you about should I invest in this, how do I implement this, so on and so forth, GoRed developed 3 questions, which were later expanded to 5 questions on how to address any such question. How does one determine when to act? This is a question that many decision makers face, and the purpose of the inherent classification to take actions is buffer management. We know buffer management acts like a traffic signal, red, yellow, and green. We have 3 regions. Green means we do nothing. Yellow means we plan in case we have a problem appear. So we plan ahead for the problem appearance. Red means the problem has appeared. We act and implement our plan. So these are some of the different methods that GoRed used and created as it relates to inherent simplicity. We use this method, inherent simplicity, in the hard sciences. The inherent simplicity, however, exists in reality. The point is, if you do not assume a priori that the simplicity exists, you will never have the stamina to go about finding it, because it's not a triviality at all. This is what we're doing in theory of constraints all the time. The systems are enormously complex. Wait a minute, there is inherent simplicity. The thinking processes are the tools that help us to find the inherent simplicity. 2 areas exist. One is those areas where we have already found the inherent simplicity and we just use it. In other words, if somebody's already applied the thinking processes to a given area, there's no need for us to go back and start from scratch. We can take their solution, use TOC, theory of constraints thinking processes, to check their assumptions about the environment and about the use of their solution, and see whether their solution fits our environment. Or the second approach is in those areas where we haven't found the inherent simplicity. In other words, perform the thinking process analysis for that area. The first step is to find it, to find the cause and effect relationships that exist in that environment. Now, what I want to emphasize here is that I assumed that Alex Knight's solution and 5 other TOC experts in healthcare solution to how to run a emergency department is correct. So what I look at is that solution. What do I need to modify from that solution to implement it in a given emergency department? So we have known solutions for several links in the healthcare wicked problem. And so I'll use those solutions in solving the wicked problem. Now, in my opinion, I try and point out what's my opinion. GoRed used these inherent classification and inherent simplicity concepts to develop many of his TOC solutions. He verbalized the inherent classification concept and the goal in 1992. And chapter 38, he talked about classification. He called it the intrinsic classification. In 2010, he called this the inherent classification. So prior to GoRed's work, much of these areas that I've just covered, I think, were considered ill-structured problems. And his solution process solved and converted those to well-structured problems and solved them. My opinion. Let me move to point 4, Simon's principle of hierarchal decomposition. Now, this is key to developing solutions to ill-structured problems. Simon describes the structure of complex systems and how one decomposes a complex hierarchical system into simple, similar structures for study. Now, Simon was talking about quantitative analysis when he made this statement. What he took was a hierarchical system, an ill-structured problem, and he decomposed it, went down the levels hierarchically from the complete mess, from what's the top hierarchy in that system to what's the lowest hierarchy in that system. And the lowest hierarchy was problems in our healthcare at, say, the hospital level, the primary care provider level, nursing home level, so on and so forth. In my opinion, again, I like to state what was not stated by the researcher. My opinion of reading the material is he states into simpler, and I add or dissimilar structures. And I say that because Alex Knight has several solutions that revolve around hospitals, operating theaters. I worked in primary care providers. Gary Wadwa worked in surgical providers, as did Gustavo Bacular. And so these are similar, some are quite dissimilar. And what we're going to do is to hook these together for a complete solution. So Simon's principle of hierarchical demands applies, I think, more appropriately to qualitative analysis than to quantitative analysis. There's not much that's ever been done in linking qualitative solution or quantitative solutions together. But I think it makes quite a bit of sense to work to link qualitative analyses together by using logic. The third point is the system improvement is achieved at the operations level, the doer level in this system, the provider of healthcare, and not up at the strategic level. The fourth point is that solving the ISP is only possible if chaos is removed in the lower levels so that you can actually calmly address that level. Simon defines a hierarchical system as a system that's composed of interrelated subsystems, each of the latter being in turn hierarchical in structure until we reach some lower level of elementary subsystem. So I start at the top level and I keep decomposing the system to reach the bottom level, the doer level. Let me give you an example. I think it's an example of the application of this. It was provided at a TOC ICO conference by Kristen Cox, and she's no relationship at all to me, but a brilliant woman. I went out to the Utah government website. The government has 21 agencies. The state government is composed of 21 agencies, 295 departments, 22,000 plus employees. These are the lists of the 21 agencies. I have in parenthesis the number of departments in that category of agency. So you have 295 different departments there. And I stripped that out of pages on their website. So that looks like a mess trying to manage all of that, does it not? Actually, what she did was she looked at the work environments. She had defined 8 different work environments for all of those agencies. If she looked at distribution inventory, there were 3 of those agencies that fit under that category using similar type information systems. Marketing or outreach type environment, there were 7. People environment, there were 9. Processing of transactions, 35. Project type environment, 24. Regulatory type environment, regulatory, I mean the justice system, maybe the management of timber for the state, management of wildlife, so on and so forth. Or that might fall under resource management. So there were 10 there. So she had 8 different work environments, 8 different templates that she modified slightly from one to the other to have 114 different systems. So notice she went from 22,000 to 295 to this, to that, to 8 different templates that she needed to work with. Now, let me go to the 5th tool, Knight's principle of time-based dependency. Alex's work in healthcare spans 30 years, probably. This, in my mind, is a brilliant solution. I think you can read other people's work in entirely different fields and learn a significant amount and bring it back to your own environment. But let me talk about this, because I think his principle here does the same thing, but in a much more complex environment than Simon's principle did. In a complex system such as healthcare, where thousands of patients' flows exist in situations of high uncertainty, and we know in TOC high uncertainty means we have a long-tailed distribution. We have Murphy strike, that where Murphy struck may take 3 times the mean or the average of the system and distort that patient flow or other flows. And in TOC, we're trying to trim that long tail distribution. So the provider cannot determine the patient flow until the patient's treated at the current length. So you have massive uncertainty. The doctor treats the patient, the doctor determines whether the patient is well and they don't have to see him again, whether the patient needs to come back for a visit, whether the patient needs to go to the hospital immediately, whether the patient needs surgery, whether the patient needs to be referred to another doctor. So you can see the tremendous uncertainty. So Alex's solution allows you to plan and control in this environment. That sounds awesome, doesn't it? Let me quickly show you the solution. So we have people coming into an emergency room. The emergency room can send them home. They can send them to an assessment unit where they're held for 5 or 6 hours maybe, and then sent home. I can send them to an operating room immediately. They can send them to a medical ward, specialty wards. So you can see all the possible paths. You can see over the GP referral, that's my primary provider over there on the left. You can see my pointer here. That primary provider also introduces people into that network of resources. And you see, I think Alex said that they had documented 46,000 different flows and then gave up on trying to document all the possible flows through that healthcare mechanism. So his solution was to put buffer management, let's say, in front of the operating room. You see my pointer, buffer management there, and to measure the input into the operating room, find out what the long tail was, what is causing the wait time between, let's say, the assessment unit in the operating room and then trying to identify the cause and trim it. So what his solution actually does is take those long tails between and among the links and then trim those tails so that the waiting time from going from any one unit to any other unit is reduced significantly. He's not trying to map everything. He's only trying to identify the long tails for given units in the healthcare system and then find out the cause and trim the cause. Brilliant solution. The sixth point that I'll use is called a frame, or your perception of an environment. It's a complex set of assumptions, beliefs, values, attitudes used to create meaning. That's called a frame. Frames biased your understanding of an environment. Tversky and Konnikon in 1981 used the term decision frame, and that being the decision maker's perception of the environment and making a decision. Mabin and Davies took this framing concept and used the evaporating cloud to frame a person or two people's perception of a conflict or a problem. And then they use multiple frames to understand the impact of views of different constituents or stakeholders. And this actually falls, as you know, straight in line with developing the generic cloud, which looks at clouds from different stakeholders and then tries to come up with one cloud, the generic cloud, the three cloud approach within TOC. I won't go into this much, but I provide several examples, and that's an organization, a person typically has an external and internal frame. I provide the example out of Schregenheim's work, Ellie's work. Thank you, Ellie. And this is the frame that a cloud between a link in a chain and the chain. It shows the problem of collaboration. Do you collaborate with the chain or do you not collaborate because of your own financial interests? And then what's driving your decision as a link is you have an internal frame that says I must control my own costs and I must increase revenue. So the assumptions that I build in that internal frame impact how I view my external frame. A person should understand and have a good idea what the internal frame of the other person is in developing a solution, a win-win solution. Again, I briefly defined this earlier. In TOC, we talk about a leverage point for a significant, to provide significant improvement. The TOC dictionary provides the critical chain in project management as a leverage point. I define that we move above, for example, that one project to an organization that has multiple projects. So they have what I call a strategic leverage point. They might use this is a single project. They might use a strategic leverage point, which would be the integration point for releasing those projects within their organization, the timing of releasing multiple projects into an environment. So we've moved the system up from the single project to multi-projects. The system has grown from one project to how does an organization manage several projects with using the same resources, so on and so forth. The solution again is a integration point, and I would call that the strategic leverage point because we're looking at a bigger system. Same things happens in manufacturing. If you look at Ellie's first book, he talks about syncing manufacturing. the strategic leverage point in manufacturing with simplified drum buffer rope certainly is. The central warehouse. His next book, a number of years later, talks about the supply chain and how the central warehouse, now the strategic leverage point, links the customer's demand to the supply provided by manufacturing. So it provides the leverage point for a much larger system. The eighth tool that I use is numerous TOC tools. I'm trying to reduce the chaos. I define chaos as complexity, uncertainty, and local optima, all existing in the same environment. Complexity is the environment we see where we have traditional management, traditional people actually addressing a symptom instead of the core problem. So you might go into any organization and ask them how many projects, improvement projects they have going on. If they say 15 or 20 or 30, that's an understatement. Most places have 100 projects going on when you look at the different departments and plants, so on and so forth. So that's the complexity of the environment. Uncertainty is knowing an event will happen but not knowing when. For example, our primary care practice has over a 20% no-show rate. I know that we'll average 20% people not coming to their appointment. I don't know who the people are. I don't know when that will occur. So I have massive uncertainty in trying to plan to reduce that uncertainty. And then local optima. This is a massive problem. Almost every organization suffers from this problem, and they don't realize it. We never talk about it. And that's the problem of everyone trying to be efficient at their own tasks. They stage their whole day about being efficient about what they're doing instead of being efficient and effective in supporting the system. So if we had high complexity, high uncertainty, and high local optima, we have a chaotic or disharmonious environment. If we implement the 3 processes of ongoing improvement, the change question sequence, in other words, the thinking process, we identify the causalities and address the significant problems. And we use buffer management as a signal to tell us when there are problems that we may encounter in our environment. We plan ahead, and we use the 5 focusing steps. We identify the constraint where it should be. We tell everyone how they should operate to support the constraint, instead of doing the best they can at their own job. Then we have harmony in that environment. Let's examine a few examples of how we put all these pieces together to solve a wicked problem. I'll use the puzzle analogy, and I really think this is appropriate in TOC. In TOC, we're trying to put a puzzle together on how to improve an organization. We see a bunch of pieces like that. How do we approach those pieces to provide an effective solution? Here, our objective is to put this 500-piece puzzle together, but how do we do it? I'll use the concepts of satisficing, inherent classification, and simplicity, so on and so forth. This is my puzzle. I'm using it with permission. It's a puzzle of butterflies, 500 pieces. When it's assembled, it'll look like this. There are 5 rows and 5 columns, 20 butterflies. So how should we approach putting that together? We want to go from the hierarchy, the pieces, down to the logic, the inherent classification of how I should take those 500 pieces and sort them so that I can easily put the puzzle together. I have the puzzle pieces. My first step is, and most people's first step is, I divide those pieces into the exterior or border pieces to the puzzle and to the interior pieces. Maybe I take those exterior, this is an example of that. The outer border is my exterior pieces. I've got one pile of those and then a pile of all my interior pieces. I take the exterior pieces in and probably look for the four corners, try and find those pieces I think that go to the top, those pieces I think that go to the bottom, to the left, and to the right sides. So I've moved down my hierarchy from the mess that I had at the top, the 500 pieces, and I now have far fewer piles of puzzles. The interiors, I probably sort out into butterflies first, those pieces that have parts of butterflies on it, and those pieces that don't have parts of butterflies on it. I then probably take the butterflies and sort them into the 20 different butterflies. And then I might even position those 20 different butterflies into where they appear in the puzzle. So this is what I now have. I've got the 20 different butterflies as my next stage there. And then I probably take my other pieces and I'd probably sort them into blue pieces with writing and solid blue pieces. So that's what I'm doing there. You see, I've marked off those pieces that have writing and I've got them in one pile, those that have nothing but blue in another pile. So this is what I've done to my puzzle. Look at the box there. This butterfly is right over here. This butterfly is right down here. This container, if you see my pointer, or the edge pieces, this is my all blue pieces. So I've used the concepts of satisficing. I wasn't trying to find an optimal approach. I just, as I went, made decisions that allowed me to achieve the objective of putting the puzzle together. I used inherent classification. I wanted to achieve the purpose of putting the puzzle together. So I sorted it into, classified those pieces to achieve the purpose of putting the puzzle together. The inherent simplicity, how do I sort them to put the puzzle together? I went from the whole box, 500 pieces, by the principle of decomposition or hierarchal decomposition, going further and further down to the different entity levels there. And then I use the principle of time-based dependencies. How do I put these pieces together at my logical unit of analysis to build and achieve the puzzle? What's my sequence, the causality in putting these pieces together that allows me to complete the puzzle? So in putting the puzzle together, if you look at my numbers, I probably put the border together first. Then I took my my 2 second, and I chose these because I had 2 edges in the puzzle, 2 borders to connect the pieces to. Then my 3s, you'll notice after I put the 2s together, I have 2 borders to put those together. The 4s, I also had 2 borders, so I put those together. And the 5s, at that point in time, I had 2 borders, so I put those together. And then the 6 I did last was I filled in all the areas around with blue and blue with writing. So that gives you an example of how I use those principles on, quote, what looked like a seemingly complex problem to develop and execute a solution. Whoops, sorry. I think I'm causing problems there by trying to go back a slide, but all All right, that's the detailed solution I just went through there, and lists what I did there. So this is the problem solved. Now that you've seen several of the states or the tools applied, let me move to the solution process in healthcare. I'll first state the solution process. It's 2 stages. I want to go from a ill-structured problem to a well-structured problem. Then I want to solve the well-structured problem in the second stage. I'm going to emphasize the first stage and briefly cover, if I have time, the second stage. What's the core problem of the ill-structured problem? So what's this telling you? You need to do a thinking process analysis. You need to understand the causalities and identify the core problem. In healthcare, Alex Knight, after 30 years or during that 30 years of work, identified the core problem of healthcare, and that's a lack of resources to do what needs to be done to treat all the patients that need to be treated. Second is to list the various stakeholders in the ill-structured environment. You want to do that because these stakeholders place restrictions on the entities in that environment, so you need to act within the laws and regulations that they place on the entities. The third is to apply the principle of hierarchal decomposition, Simon's work, using inherent classification and inherent simplicity to decompose that ill-structured problems into smaller, similar, and dissimilar, well-structured problems. Then use Knight's principle of time-based dependencies, again based on inherent classification and simplicity, to sequence the organizations to show the general flow of patients through that system. Then you want to frame the hierarchical conflicts from upper to lower level to the logical unit of analysis. Then you want to identify the strategic leverage point for scheduling and executing that flow. And sixth, you want to buffer between those entities and then use buffer management to reduce the wait times. That's what the buffers are. They're the wait times between the links, and to synchronize the flow across the links of patients. Then last, you want to subordinate to all of the stakeholders necessary conditions, the rules and regulations that they place upon you. So the second stage is we just take existing and modifying templates for the various cases that exist, entities that have been solved, or we develop new templates for the missing links. And that's the process of doing that. I won't go through those points of developing a new solution. You're aware of that. Knight also provided some good criteria for seeing whether you had a good solution or not. I list these here because I think they're a fairly comprehensive set that can be applied to any process that you design. Let me give you a 10,000-foot view of the healthcare system, and then I'll paint in some of the details. Stage one. What's the core problem? We don't have enough resources to treat all the patients. The list of the various stakeholders is on another page. I'll show you that. What we want to do in healthcare is we want to decompose the national environment, which in the U.S. is Medicare, Medicaid, Veterans Administration rules. The EMTALA is the Emergency Medical Treatment and Labor Act. I'll mention that briefly. That has massive impact on healthcare in the U.S. and massive costs, unintended consequences that I mentioned earlier. I want to take that national environment and decompose it down to the logical unit of analysis. Where should I stop in decomposition? And that level in healthcare is at the hospital, the practice, medical practice, the operating theaters, nursing homes. That's where I need to implement my solutions. The third point is apply the principle of time-based dependencies to sequence the organizations in a logical process flow. Now, in the US and in many other countries, the primary care provider and the emergency department are the major first links in the healthcare network. A patient has to go through either the primary care provider or the emergency department, and then is referred to other links. Frame the hierarchical conflicts. All this is saying is take the laws and regulations and everything that are given by the national, state, county, and community levels. Make sure that you're aware of those and how they impact the unit that you're analyzing. What restrictions are the national, state, county, so on and so forth, placing on that local unit? What restrictions do they place on the hospital? What necessary conditions, what restrictions do they place on the primary care provider, so on and so forth? The strategic leverage point. Determine that. As I said, that's the primary care provider and the emergency department, because they start the whole process. And each of those links determines what the next link is. Where should the patient go from here? We buffer between the links, and we use buffer management to reduce that buffer, which is the wait time, and to synchronize across the entities. This is how I'm solving the ill-structured problem. I'm linking those well-structured problems together to come up with a solution to the ill-structured problem. Again, everything is subordinated to the restrictions placed on it by the various stakeholders. There are existing templates in healthcare for many of the links. The solution that we developed at Laurie and Tim's practice as a solution and for primary care. Knight provided several different solutions. They're discussed in his excellent novel, Pride and Joy, where he discusses each of these areas and the solutions in an enjoyable manner. Maria, so on and so forth, as a TOC expert, she has an excellent presentation in the TOC Healthcare Archives. There are 6 other TOC explanations of TOC implemented in emergency departments. Wadwa and Bacular are 2 doctors. They provide case studies of implementations in surgical specialty practices. Maven talks about and presents background and solution in cancer treatment and nursing home decisions. Johan Group talks about the use of healthcare, the implementation of healthcare and home healthcare, delivering healthcare to people in their own homes. And he uses, interestingly, the TOC supply chain solution to provide and staff and execute healthcare in home. As I said earlier, Boaz, he actually has a new book out, and Suzu have books that are based on the application of TOC and healthcare. So all of these are resources that discuss existing templates. And of course, my research, I tried to generalize from that one practice solution in 2010 and develop a template that can be used as a baseline in any outpatient scheduling environment. So Knight's view of healthcare was like a supply chain network, and these are the solutions again that he provided. Stage 2, I've talked about how to do that. Now let's go down to the level. This is his cloud that basically says the demand for healthcare is far greater than the supply. We cannot meet the demand for healthcare, and his solution was to implement the TOC tools in there, which allow them to provide more, better, and timely healthcare given the budget. Here, this is my list of stakeholders in the healthcare environment. The various stakeholders: patients, pharmacies, state government, primary care providers, hospitals, Medicare, emergency departments, nursing homes, federal government, state government, so on and so forth. Using the principle of hierarchal decomposition, I go from the federal level in the US, the federal level of the laws, the agencies up there that dictate how the local level operates. I go to the state level. There are 50 states in this country of the US. Each state has laws that impact how that local level operates. In Georgia, there are 159 counties that dictate how those units operate. So I move down using that principle of hierarchical demand down to the, from an ill-structured problem to the local level, the well-structured community, the entities at that level, the hospitals, the providers. And here again, there are a massive number of potential flows. So I use buffers to link those units together. At the primary care provider level, this is what I have. I've got new patients coming in wanting acute or regular appointments. I have recurring patients, established patients that make an appointment as they leave for another appointment with a provider. And I've got established patients that call back in. They don't have a current appointment. They call in. They may need an acute appointment or a regular appointment. And the provider, the scheduler, tries to address all of these, develop a schedule. The provider, in addition to treating patients, can refer that patient to the next link in the supply chain. And in the US, there are over 120 different medical specialties. So you see where Alex Knight got his 46,000 different flows. To link all of these, we use buffer management. Again, his solution is brilliant. These are the different rules and regulations put on the healthcare organization that they have to follow. We see these rules and regulations applied to the different links. Insurance companies have their cloud, government has their cloud. These are the different clouds. External frame, the rules that they apply, and you have to look at the internal frame to understand the logic of why they are placing those restrictions on that next link. The same with the government. They have a restrictive budget, so they place rules and regulations on providers, hospitals, so on and forth. And the government has that restrictive budget, so they keep cutting what they're giving different programs so they can fund new programs. Here again, we have all of these different areas applying different rules to each link. So this is what makes the problem messy. This is an example of one rule we have a rule, many years ago, poor people were turned away from the emergency department because they couldn't pay for treatment. Congress, the U.S. Congress passed a law in 1986 that said any patient cannot be turned away from the emergency department because they don't have insurance or can't pay for it. So the emergency department has to treat every patient that walks in the door. Congress, however, enforced it, but they didn't fund it. So hospitals were left on their own to go after the patient to try and get funds or to write off that bill. And if they write off the bill, but still incurred the expense, who incurs the cost of that visit? The patients that can pay. Agreed? Let me give you a quick example. This is about 2014. There were 136 million visits to the emergency room in the U.S. The average bill was $2,100. 43% were admitted to the hospital for a stay of about 4.5 days for an extra 10 million. The total bill of that $3.5 trillion just for emergency room visits was almost $900 billion. Yet, if we looked at that 136 million, over 70% of those patients, if they had seen a primary care physician in a timely manner, would have never had to go to the emergency room. So think about emergency rooms being reduced 70% in size. Thinking about hospital rooms being reduced by 70% in size. If we did the math and we said 70%, that 70% went to a primary care provider or a specialist provider, and it cost $160 versus the $2,100. The total cost then would be $315,000 instead of close to or 315 billion instead of close to 900 billion. So that the unintended consequences of that law cost government insurance $576 billion a year. Now, how should we structure a system to handle that close to 100 million patients or visits a year to the emergency room where they shouldn't have gone there? By the way, if you divided that number out by the number of primary care providers, it comes out that each primary care provider would have to treat 2 more patients, 2 appointments a day would cover that number, that 100 million people that go to the emergency room that shouldn't. Now, at the same time, recognize that the no-show rate is over 20% of a primary care provider's time. So the primary care provider, if they could effectively schedule and execute, could handle that 70% of patients. A recent study said even well-managed practices have an average no-show rate of 20%. Notice it also says that many practices have a no-show rate of 50%. Why don't people show? Because the appointment is not timely. They call, they're sick, they want an appointment today, but tomorrow they're given an appointment next week or the following week, or in one case, I called a specialist and I was scheduled 6 weeks later for a sinus infection. So what does a patient do when they're sick and they want to see a doctor and they can't? They go to the emergency room to get timely treatment. They try another provider, emergency care, pharmacist, so on and so forth. The longer the time till that treatment, the higher the probability is that they may end up being admitted to the hospital. So, as I said, the primary care provider and the ED, emergency department, are the gateway to the healthcare. These are some of the days wait times. If you call for an appointment today in the US for these types of appointments, these are the number of days you would wait. So that gives you sort of a time scale, but recognize the family practice is the gateway. So it actually looks like that unless you're a current patient of one of these specialists. So if I call today and I was sick and the doctor, if I'm a new patient, usually wants me to have a physical first, look at the length of time if I had a heart problem to get to a cardiologist. What's the easy thing to do? Go to the emergency room. Now look at the common no-show rates of these practices. Notice the primary care is 20%. That's a recent study. Yet, if we looked at a primary care provider, 20% no-show rate means if they have a 5-day work week, they're idle one full day. One full day. So that sort of tells you we don't know how to schedule. We don't know how to execute a schedule. This, I said earlier, was my definition. I provided a new definition. The definition is based upon TOC. I'll leave it to you to read and understand that. There are a couple articles written on this definition and what it means, and I provide the abstracts for some of my work and some of the presentations that I've made at TOC that discuss this. But for details on how to implement TOC and what's needed at the single practice level, the 2012 presentation is good. There are other presentations the whole way up to the generic solution for scheduling. What to change? What if we were able to convert the ill-structured problem to similar or dissimilar, well-structured problems? What I would want is patients, particularly acute patients, are seen in a timely manner. Timely to me, if you're sick, means same day. Scheduling chaos is eliminated and the scheduler proactively manages the schedule. This is not done today in any environment that I know of. Proactive management using buffers to manage the schedule. The no-show rate and late cancellation rate are minimal. I call minimal 2%, 3%. So instead of 20 or 30 or 50%, if you could get the no-show rate by proactively managing that schedule and the execution, we would not have the healthcare problem that we have today in this or any other country. All patients are provided excellent health care, and TOC, what does that mean? That means a provider focuses on the current patient, no interruptions, everything's at hand, so on and so forth. Provider skill levels are highly utilized. The provider doesn't walk the patient back out the practice, doesn't walk the patient in, doesn't take the first description provided by the patient. In execution, we've eliminated all the chaos. The provider does only high skill level tasks, has no interruptions, no multitasking. They're focusing only on that current patient, and full kit, everything is there to treat the current patient. So let's suppose that a newer established patient would call the scheduler and get an immediate appointment. The scheduler would triage the patient, ask if this is an acute visit, do you need to be seen today? Or do you have a health concern and you need to be seen in the next couple of days? Or is this just a routine appointment that you want? So we triage the patient in that manner. The scheduler also has to, the provider releases well patients back out to the population. The provider also takes, once a new patient is scheduled and seen by the provider, they are now a established patient, now that I have a record on them. Does a provider want to see them next week to ensure that whatever the treatment was effective? Or does a provider release them to the population? Or does a provider refer them to one of 120 medical specialties? Now, when I triage these patients, you notice I did it in red, yellow, and green, my buffers, right? We have new and established patient, a routine patient, the appointment can be greater than 5 days, a recurring appointment as specified by Medicare, Medicaid, insurance, whatever. Concerned patient, I want to get into the practice in 1 to 5 days. An acute patient, I want to get in today. So the role of that scheduler is to triage the patients. Oops, emergency patients, I don't want to see you. If you've got a healthcare emergency, go to the emergency department. Do not come to this practice. So the scheduler triages the patient, and these are the rules that the scheduler follows. This looks like something like this. Acute patient referrals are 1 day. If I refer you, I call one of these specialists. They have allocated blank appointment slots in their schedule that are only filled each day by acute patients. So they fill those acute patient slots each day. If you don't use enough, you're using buffer management to regulate the number of appointment slots that you have in your appointment schedule. Regular patients, acutes are same day. If I'm already going to a cardiologist and I call the cardiologist and say, I think I have a problem, the cardiologist scheduler should say, well, come on in. We have an appointment at 3 o'clock. I did this. It was really interesting. I did this with my urologist. I called and said, I need a appointment, an acute appointment. I like to see my urologist today. And the lady looks at the schedule and says, well, I've got an appointment opening in 6 weeks. And I said, well, wait a minute. I've got an appointment. My regular appointment with my urologist is in about 3 weeks. Forget that I need an acute appointment. I'll just talk to him at my regular appointment. So that's the type of environment we face in this country and trying to get appointments. And it's not the provider's fault, it's the system's fault. We have not got a system that links healthcare units together in a network. As I said, I wanted to come back to this point here in this solution process with regard to Ackoff's statement. He made the statement, a whole that cannot be decomposed into individual individual parts. And what I'm saying is, yes, I divided them into individual parts, individual systems, and solved that system, that part, the primary care provider, Alex Knight, the emergency department, and this link, but they are linked together by buffers, and the buffers do what? If we go back to my initial cloud, back on slide 2 or 3, the evaporating cloud requirements were patients receive excellent, timely health care. How do we do that? We link between the links, and we use buffer management, which reduces the wait time between the links, which means we're in that whole system is much more responsive. And when we link those links together, we also meet the requirement of providers are effectively utilized. In other words, instead of getting an appointment 6 weeks later from my urologist and me not showing up for the appointment because I ended up in the emergency room and didn't cancel, I am treated the next day or that day. So the likelihood of a no-show for the provider is decreased significantly. So by linking all of those components of the ill-structured system together, I in fact achieve my requirements for the whole system, where we have timely health care and a high utilization of the provider. So I think this is probably a good stopping point here. I've started on a solution for education and provide some of my thoughts here just to illustrate the steps involved in the process. And you can see what my thoughts were as far as the stakeholders and going from the national level to the local level, the different school system there, a different school, primary care, middle, secondary, where you apply it, how you break the years down into time elements, and you see the enforced buffers in that system by having summer off, weekends off, afternoons off, so on and so forth, and different laws that apply in education. In education, my solution was to take the lower third of every class and give them intensive instruction and try and move them back up to the class mean. So if I do that, if I take the lower third in every class and give them intensive education in the subjects that they're low in, I try and bring them back up to the mean of the class. And when I do that, what happens? I improve the mean and I reduce the standard deviation, which allows me to teach at a higher level in the next class. So if I continually take the bottom third, much smaller classes, much more focus on where they're weak, I'm continually improving students as they go through the system. Does that make sense? I hope you're saying yes out there. So that's what it looks like, some of the and what's happening during those 3 segments that I showed over there. And there are solutions. An excellent solution was provided by Rami Goldratt and Weiss for a school in Israel, where they applied theory of constraints and had significant improvements in performance. So that, in my mind, is a proof that TOC is an effective tool in trying to address the education problem. There are other solutions. I think Marcia Hutchinson in around 2011 or so gave a TOC ICO presentation about the use of TOC in a school that she was involved in. There's also TOC for Education, a sister organization that have developed numerous tools for improving education. So these are some of the applications from the TOC for Education website, and where TOC has had significant impact. This is a abstract of Rami's research in Israel. Here I tried to address, apply TOC and recidivism, that's criminals ending back up in prison. I have a quote here where 75% of prisoners return to prison within 5 years. And think about that. You've got new prisoners coming in, and you got 75% ending back up in prison. So you've got an expanding problem. I think anyone interested in powerful solutions ought to read Christina Chen's chapter 27, TOC in prisons. Her discussion of getting prisoners to buy into the use of logic is extraordinary. I think she really understands the buy-in process and the difficulty in these types of environments where you need people to buy in. Excellent work there. And that's my hypothesis. In my lit review of this, these are some of the factors: criminal-prone individuals and what causes that. So I tried to address that. I've come to the end of my presentation now, and this is my two granddaughters, and they're playing doctor. And so what I hope I'm creating is an environment that them and others could dream about. Not necessarily what we have today. The end. Thank you very much.
Whoa, Jim, this was truly mind-blowing. Great presentation, a lot to think about. I'd like to open now the stage for questions. And if I just may, to put one question. You touched upon it that when you do your hierarchical decomposition, you are trying to get to the lower level in order to solve, at least to solve the flows, is what I understood, within the lower level. But you already mentioned the possibility of conflicts between different hierarchies, also maybe between different links. Like the primary care provider who does not want emergency cases to come to their place, but what do you do when they do show up? These are some, which means there are still more open problems because eventually it is what you call the ill-structured problems composed of more than just one key problem. Am I right?
You are correct. And we marked that down. I said, you are correct. What'll happen is you're always going to have people that violate the policies and procedures. What we've done, though, let's say for the no-show problem or the walk-in problem, patients walk into the practice, don't have an appointment, so when they walk in, they're treated that day, but they disrupt the rest of the schedule. So in Tim and Laurie's practice, they encourage all patients know immediately to call in if they have a problem because appointment slots have been reserved for them, and it's better to call in than walk in. And I think they emphasize that so much, and patients know that when they call in, they're going to get an appointment that day and do not have to sit in a waiting room with other sick people, to wait to be treated if they walked in. So they've reduced the noise significantly. And yeah, you're still going to have people that violate that. My mother, she's passed away now, but she talks about going to her cardiologist and sitting in the waiting room, and then a woman came in and she wanted to see her cardiologist, and she said she was having a heart attack. And guess what? She was having a heart attack. So the emergency room or the clinic called and had an EMS, emergency medical team from the hospital come in and take her in an ambulance to the emergency room to be treated, because believe it or not, the cardiologist's clinic isn't set up for you to have an emergency or a heart attack. So, yeah, but if you only have 1 or 2 violations, you're down to 2% no-show rate. This practice, my understanding, I went back in 2015 and audited it, and I talked to the scheduling supervisor who was unbelievable. She took the TOC like nothing I've ever seen. She developed her own solutions. They called every no-show patient, now you're down to 2% no-shows, every time the patient no-showed, they called them that day or the next day, and they identified why they no-showed and how they were going to address that problem so they would not no-show again. Her comment to me was, we've never had anybody no-show twice.
Great.
So that's in execution. You've got to do things in execution that help you out in scheduling. Those two functions are highly related and intertwined. If you don't have excellent execution where a patient can come and be seen within 15 minutes of their appointment time, then they're going to start showing up late for their appointment, and they're going to disrupt the schedule. So it's important to address both core problems.
Yes, and there could be maybe more for a national, what you call its structure problem. If it is a national, there could be more than one core problem, and then you need to solve one at a time.
Yes, and that's what happened. That's why I put the diagram there with stakeholders. I think if, and I've not heard Christian Cox talk in several years, nor been able to find much that she has done, but Kristen would identify problem or laws that were blocking the treatment of, let's say, people in poverty, where
yes,
the spouse had a problem and was trying to get educated, but if he worked more than 20 hours a week, he wouldn't qualify for this program. He had to work less than 20 hours, but to support his family, he had to work more than 20 hours. So she encountered numerous conflicts in trying to solve family problems because the law applied to individuals. For example, convicts can't apply for housing assistance and many of the laws. And I show a web page where that shows you one of the problems. So how do you address those conflicts? Well, you call up the other stakeholder that imposes those conflicts, and you've got to know why. You've got to know their inner cloud of why they're imposing it, and then try and show that this is a win-win solution for them. You've solved their inner cloud, plus it allows you to solve the external cloud. So it's a different way of looking at buy-in, and I think Alan Bernard, as you said, started that discussion, and I sort of came around to the same conclusion, and then you took the wind out of my sails by telling me that Alan had devised this 7 years before.
All right, this is good that we do this kind of things. But Jennifer, do we have already some questions?
Yes, we do, Ellie. Okay, so first is a comment just from for Jim from Sanjeev Gupta. It is saying good decomposition of the chaos. So next is a question from Rex Williams, and it says, what if the puzzle picture is more complex, like clouds or something?
I'm not sure that I know. My solution process here is a straw man. So I realize it won't work in all environments. I think there's probably different types of ill-structured problems. I think my solution process will work in the structure where there is this hierarchal network that where you have people at the top imposing restrictions on people below them. And there are probably other types of ill-structured problems where that structure doesn't exist. So I don't claim that this is a solution to everything. I think it's a starting point for a given type of wicked problem. I cannot tell you, I'm not sure I know of many environments that are more complex than healthcare in the United States, or education, or crime, or poverty. And the treatment of those areas are governed by a hierarchical structure. Federal laws, state laws, county laws, restrictions placed on them by a number of other people. So in my mind, now that I've looked through this magnifying glass, everything looks the same. It all looks like this hierarchical structure. So I would say take the environment that you're thinking about and then try and apply what I'm talking about here and see if it works. And if it doesn't, find out why and how to modify the rule.
I have opened up Rex's mic just in case he has some follow-on for some dialogue. Rex, does that answer your question?
Yes, thank you.
Okay, great. At this time, I'm going to open up the microphone for John Ricketts. He has several questions, so just one second. John, are you there? I believe John is through a phone, so let me ask the questions and we can go from there. So his first question is, what about the provider charging no-show fee and granting discount if provider is late to the appointment? If there's no cost to either party, it's no wonder the no-show rate is high and patients are frustrated. Do some providers overschedule because they know what their no-show rate is? If no-show rate is 20% and the overschedule is 10%, that at least cuts off the problem in half with some occasional overtime on days when there are fewer than 10% no-shows.
All right, let me go back to your first question. Let me address those one at a time. Ask the first question, let me try and respond to it.
Okay, so first question from John. Okay, so here we go. What about the provider charging a no-show fee and granting discount if provider is late to appointment?
If the provider is late to the appointment, usually, well, actually in Laurie and Tim's practice, the provider, most of the providers had physicals scheduled at 8 o'clock in the morning. So you had the provider scheduling 1 or 2 physicals, both at 8 o'clock. You had one desk where they were received. You had six providers having patients go to that one desk to check in. At the same time, when a person came for a physical, they were weighed, they had an eye test, they had to be processed by the nurse. So you had backlogs at the check-in desk, at the wait station, at the eye chart station, and then if a provider had 2 appointments, they only had 1 CMA to process both of those patients. So you had lines formed everywhere. The provider actually was in their exam room at 8 o'clock and the patient wasn't there. So the patient ends up showing up, first patient, maybe 8:15, 8:20, and their lateness is caused by the way the system is designed. You've got all providers scheduling appointments at 8 o'clock. One of the solutions was, let me have my first patient a 7:50 appointment. Another one moved their appointments down to some other time to start. On one floor, they bought another eye chart. So they had 2 eye charts to process patients through. When the providers figured out that it was the lump in the system, the snake had eaten a big animal and it was going through the system, they moved some of their physicals to later in the day. So they, once they identified the cause, they were able to address the problem quite simply. So when you say the provider is late, John, I'm saying, wait a minute, is it the provider or is it the lump in the system at check-in or at various other stations? Now recognize, once that provider starts that session late, 20 or 30 minutes late, they're running behind for a long time. So it looks like they didn't show up, but they in fact were there and idle, caused by the system. So in Tim and Laurie's practice, Tim made the comment in the 2012 presentation that that lateness had occurred, and in many instances, the provider's blaming the patient and the patient's blaming the provider. That lateness had existed for 8 years in the practice, since he started on day 1 in the practice, and nobody ever was able to address it or thought to address it. They just thought it was a fact of life. When we looked at it from a TOC perspective, the CMA, one of the nurses that shows people back, identified that as her biggest problem. And that's how that was finally addressed. It was a person rooming the patient said, hey, I'm standing in line at the wait station. I'm standing in line at the eye chart. We said, oops, we can buy another eye chart for $50. So the simplicity of the solutions, and it was given by the person that recognized that problem. Can I go to the second question?
Yes, so it is, do some providers overschedule because they know what their no-show rate is? If the no-show rate is 20% and the overschedule is 10%, that at least cuts off the problem in half with some occasional overtime on days when there are fewer than 10% no-shows.
John, it doesn't work that way. So let me, the academic literature today is trying to use data analytics, these large data sets, to predict the characteristics of no-shows. Massive amount of academic research and trying to predict the no-show. Is it poor people? Is it a minority? Is it this? Is it man? Is it woman? And then try and overbook for when that type of person no-shows. That type of person no-shows, let's say 30% of the time. So I overbook. What that means is 70% of the time, both patients are going to show up. So if both patients show up and I've got to treat both of them, what does that do to the rest of my schedule after that? So that's where the academic literature is headed. What's the TOC solution? Ask the person why they no-showed and address the cause of that no-show directly. And if that's a cause that is common across the practice, then what policy or procedure can we change in the practice to eliminate that? Simple solution versus a simplified solution, inherent simplicity versus simplification. I think your last point was about penalties. Put on the provider or put on the patient. My understanding in the literature review is that they don't work effectively. It's better to identify the problem and address the problem one-on-one with the patient. In other words, they didn't have a ride, their telephone number had changed. Let me give you an instance. When we first started in Tim and Laurie's practice, they used telephone calls to remind the patient that they had an appointment. And I said, well, they had a no-show rate of well over 20%. I said, let's call those patients directly and ask them why they no-showed. They came back giving me an assortment of reasons, and they said, well, we had about 20% of the people, the number didn't work. Telephone number didn't work. So I said, let's run an experiment. Everybody that comes up to your desk, it's a patient, I said, ask them what their contact information is. And they said, oh, we would do that. I said, well, tell me how you do it. And they said, well, we ask them if their contact information has changed. I said, no, that's not what I said. I said, ask them what their current contact information is and have them repeat it. My telephone number is such and such. Well, they found out that over 20% of the people, the telephone number and contact information had changed. So a common policy or procedure they have now in the practice is to ask the patient to give them that information. Are you the contact person, or do I need to call someone that drives you or keeps your schedule? So they spend time with that patient to validate that they're doing things correctly. Now to your point of negative. I had an appointment recently with a specialist. They called to remind me of the appointment the day before, 2 days before the appointment, and I had an 8 o'clock appointment. So I called the next day at 8 o'clock saying I didn't need the appointment for the following day. I tried off and on for about an hour and a half and could not get through the line to tell them that I wanted to cancel the appointment. So I gave up. The next day I tried to call and do the same thing, but I had an 8 o'clock appointment and should have been there. And I could not get through at that point in time. So about a month later, I get a bill for $30 for missing the appointment. Now, how do you think that made me feel, John? So if your system doesn't allow me to cancel and there are problems, we're each pointing at the other person and blaming the other person. So what's a better solution? Am I able to text you and get through? Is there a line that you can provide for cancellations? It's very difficult to cancel an appointment through the system because the scheduler and the provider don't want cancellations. They're trying to protect the provider utilization. They need high provider utilization so that they can pay their bills, pay their staff. What we want to do is encourage cancellations. If you know you cannot attend, cancel immediately. There are sick people that need that appointment, and we want them the opportunity for that appointment. So that, to me, is a much more positive approach as an incentive, because they know if you're sick and you call, I've made slots available to see you that day. So I don't like the negative, and the literature is bearing out that the negative incentive of canceling or canceling or for no showing doesn't have much effect. The person just doesn't pay the bill, or they are hesitant to try and go back to the doctor when they need the appointment.
Yes, this was great.
Great. There are more questions. Can we continue?
Maybe more question from other people, and let us say now 2 more questions, and we will need to close.
Okay, so this question comes from Mohammed saying, how easy or difficult was it to have both the staff/employee and for the patients to understand and follow the new flow? And how was it planned? And were there any constraints there?
Wow. I'll tell you what, someone in our test method asked about what was the difference between TOC and healthcare and TOC in other environments. And TOC in healthcare, to me, is in real time. Your product is there, that's the patient. So you've got to be much more responsive to Murphy and execution. But if you do the multitasking confetti game and teach them the problems of multitasking, if you play the penny game or the matchstick game or any other game that shows the problems of lines when you don't plan and control versus the problems of lines after you've implemented the 5 focusing steps, it's like ducks to water. These individuals in this system were unbelievable in their ability to go from concepts of a line and playing a game to how it impacts their tasks. And I actually had all the people in the workshop list out their tasks. CMA or nurse, the one that rooms a patient, what do you do? And then I'd have other people validate or add other tasks. So I had a acetate for each type job in the flow. And then we played the games and all. And then I came back after we had gone through the 5 focusing steps. And I said, now that you know that you need to subordinate and support that constraint, that provider, instead of doing the best you can at your own job, how would you change these tasks? So they actually built the job description that we use in the practice today. I took the sequences of what they had given me and sequence that into the job description for those various positions in the practice. So it was their solution, and they bought into it because they developed it. And I would say that within 4 to 6 weeks, they had eliminated all of the major problems in flow through a weekly buffer management meeting. And we had added another 15 to 25% more appointment slots for 4 of the providers in that practice. So they were able to accommodate another 15 to 25%, I think 3 to 5 slots a day, because we improved the execution. Well, the problem got where in the buffer management meetings, even with the addition, there were no outliers. So that long tail distribution that we talked about earlier ended up being a normal distribution, very much like a normal distribution with a very small standard deviation. And it was all of their own making. After a while, they quit having the buffer management meetings, and they don't have them today, but I hope the mindset in their employees is to identify a problem and recognize how it impacts the constraint, and the pod addressed that problem. I would like for them to continue buffer management meetings just to get the concepts to other people. But I hope that answers your question there. It's just a matter of Socratically teaching the principles, let them develop the principles, and then they'll integrate that thinking into their own practices to address later problems.
Beautiful.
Good. So we'll end the session. I'd like to thank you, Jim, your in-depth insights and analysis and sharing the Strawman process with us today. And Ellie, thank you for bringing in such incredible speakers in the webinars for so many years. Appreciate all that you both do in furthering the TOC body of knowledge and supporting the TOC ICO and the TOC community. And I just want to thank all the members and guests for participating today. We hope you enjoyed the presentation.